Well, hello everybody. Thank you very much for having me here today, and I feel like I'm on the dark side of the equation because I'm the hospital administrator that has to sign for the contracts and so forth. So I really wanted to give you a perspective of what we look at and why we may be distracted, because even in Milton's emails that we have received, when we talk about why is telehealth and telemedicine only being used 0.1% of the time, if you will, in the aggregate, but this is definitely the future. I mean, that's what I believe, and I believed for many years. And it is going to be a billion-dollar industry. So you are all the, I don't want to call you the early adopters because I know you've been doing it for a while, but you're on absolutely the right track. So let me make sure that I have this. Is it changing? Not changing. Can I just press enter or? Got it? Okay. Thank you very much. Okay, so this is what I'm going to go over pretty quickly so then we can take some questions. So what are some solutions to increasing telehealth in health systems? And I'm talking large health systems. Some of the ones that I work with were Temple University Health System, Lehigh Valley Health Network. I've worked with CHS. I work with Tenet, Hahnemann, just to give you an idea of the various hospitals. And my associates have also worked with large health systems in the New Jersey areas and New York. So what we're going to go through is what were the challenges to implementing telehealth, what are some keys to success, and I just want to go over a case study with real dollars at the end and show you how we were able to justify bringing in telehealth. So solving the telehealth dilemma and solutions to increasing telehealth. So this is what the administrators think about every day. I know you may not believe this, but we're looking at what is the possible ACA repeal replace, which we may wind up knowing at the end of this week. So what does that really mean? If you looked at any of the statistics in healthcare, what you found is, and if you read Becker's Health Review, which is another good source of information, what you would find is that about 7,000 people have been laid off that we know of. Hospitals have been closing, etc. Why is that? Part of it is the reimbursement perspective, because if this is repealed, where we used to have 44 million people uninsured, and then when Obamacare came, brought it down to 18 million, it may go up to 56 million by 2026. So just that statistic and how the hospitals are going to be able to pay for their care they're rendering. Many people think that hospitals really do absorb a lot of dollars and they have a big bank of cash. Some hospitals, yes, that's true, but the average hospital has a 2 to 3% margin at the end of the day. So where's the rest of the money going? To our insurer friends. The government has to pay what it's paying, but a lot of us are working with Blue Cross Blue Shield, Aetna, and others. So depending on our contract, that's where the hospitals can depend on dollars. Now, here's your alphabet soup, of course. We know we have the accountable care organizations. We know we have MACRA, MIPS, and APMs, and discrepancies across states. Now, my understanding is telehealth has been approved in 37 of the 50 states, and that is up probably within the last 10 years. We were at 25, so it's not moving. And the problem is it is being approved at a state level, but all of them are different. There's not a consistent. So that's what makes part of this hard, is because it really is geography at times related. On the MACRA piece of it, many of you're familiar with MACRA, and that it is a law, that it was passed a few years back, so it didn't really get involved in the whole ACA repeal process. So this is an active law. It's meant for physicians. It's for Part B, and it gives physicians two ways in which they're going to get paid, and can they get an incentive payment. One thing that is new for 2018 is if you're a virtual physician, if you're a single physician or a group of less than 10, they are now putting in laws to allow for bonuses to those physicians who were not allowed to participate in either the MIPS or the Advanced Alternative Payment System. So the MIPS will now allow for virtual physicians. So you could have a group across the country being in a virtual care group that can use telemedicine and can be eligible if you follow the rules. Now, the internal factors. We were talking about this last evening. A number of us have probably worked for 4 or 5 different employers, but we sat at the same seat. So as I was sharing with the colleagues last night, basically I've worked for the Medical College of Pennsylvania and Hahnemann University, who were taken over by Allegheny General and took 7 hospitals, but unfortunately they went bankrupt and then came in Tenet. Then unfortunately Tenet didn't really want to have all of us, and so they kept St. Chris and they kept Hahnemann. Now, Palladium, if I'm saying it correctly, is coming to Philadelphia. I believe they are a California-based company, and they are now going to take over the 2 last Tenet hospitals, so they've pulled out. Then I went, thought, I'll go work for Phoenixville Hospital, right by my community and so forth, because they had the University of Penn and Jefferson and all these other great doctors on staff there. Well, that's a CHS hospital now. So you all have read that CHS every week is about selling 3 to 5 hospitals, and they're vacating. So why I brought that up with mergers and acquisitions is because the hospital administrator is on the road. You've got them. They want to do whatever your service is. Oh no, now we have to go to Cerner, now we have to go to Epic, now we have to switch around. So what you're doing is the right way to go, in my personal opinion, because you're using an iCloud or a cloud-based system. If your system, this is the only way, the last health system I worked for, I don't know if anyone's here from Trinity, I work for Trinity Health System in Philadelphia at their Mercy Health System. We had 3 hospitals. We had a large clinically integrated network. And the only way I was able to convince folks to move forward working with this is, if you've heard of Dr. Rick Gaffilin, he is the father of accountable care. If you read any of the Healthcare Advisory Board documents, he actually went, and I don't know where my colleague that just spoke is, but he was at CMS. President Obama brought him in to be the first director of the Innovation Center. So I had the honor of working with Dr. Gaffilin, so he was able to share with us about accountable care organizations and how we can get more of the doctors to join us without us owning them, because the doctors want their independence. So we would have our network and we would be able to provide care and really try and drive down the cost and be value-based. So we have mergers and acquisitions, the vendor management, that really is more the IT platform, and then we have the telehealth and telemedicine payment options. What's happening in the area I work in Pennsylvania is Jefferson just entered into a contract with Blue Cross Blue Shield for the next 5 years. So that way they will get paid for telemedicine or telehealth, and they will be able to use the different facilities that Jefferson Health has. So you see, people are going and weaving around this issue because it's really just not set up in a way that can be used easily. Now I'm going to share with you, I guess if you leave it on too long. Here? So where are you pointing? You're pointing. Okay. All right, so we'll go back. Well, what you had on the previous slide, so I'm going to try and wrap it up, is there's a puzzle board, okay? So here's the one thing that you need to understand about hospital administrators and our staff. We all are trying to do the best thing and take care of our patients, just like everyone in this room is trying to do. But sometimes we don't know what we don't know. So we have to be curious. So imagine, I wind up working in a situation, and I have colleagues, where we are trying to be able to get more patients in and we're losing them. You're offering us telemedicine, the Holy Grail. We're not answering the phone. okay? I hate to say this. We abandon calls at a rate of 20% in many places. So between the abandoned calls, the not calling the patient back, the physician and his staff are sending us faxes. We're not putting the faxes in. I'm not saying that this is purposeful, but there have been lost faxes. So a real-time system that allows a check and balance is what is needed. And so administrators are worrying about where did my volume go, and unfortunately it's gone because, like I said, we didn't answer the phone or we didn't call them back, and it has serious implications. So I'm not saying it's a widespread issue, but if you're going in to try and sell a product, I would really advise you to kind of figure out, and I'm going to give you the national best practice standards so you know, is this system okay initially before I go in to offer them something else, because you could provide them with dollars that they don't have. So here we have employee insurance, which is one of the key components for, from the patient's perspective. I would urge you, if you're selling your telehealth product to a hospital administrator, go to the HR person, have them in the meeting, because the best way to get buy-in is to take care of the employees there themselves. So we put in a system called Friends and Family, and therefore it was a hotline, and if our employees needed to get in, they were able to see that it works, that we are committed, because we really were committed, we just didn't realize there were these glitches. Insurance verification. We set up a system that all of these things are being done out of one place. We centralized it. You don't have to always be in the same place to centralize, as you know, because you can do it through the cloud. But the majority of these systems were centralized. So you go in and you can make sure that insurance verification, or how's that going? We're losing money every time we get denied because we don't have the right information. So satisfying our employees is recruitment and retention, insurance verification, stopping denials, real-time scheduling, so we know it's taken care of, we didn't abandon calls. Marketing and communication, they can use this whole system too that you're offering, plus what they need to do inbound and outbound marketing. So if it's, you know, mammograms for breast health month, or it's this for colon cancer, we can do outbound, recruit, and market. So try to think of your systems in ways that if you have something that can offer to tie in with this. Population health, we have all these nurse practitioners and they're trying to follow that patient all the way through the process, and we can't lose them. As you know, with the ACA, and we'll see where it goes next, we got to cover it live. So I own that covered live, unless my friend from CMS or Noridian can answer. We own that patient, and we're supposed to take care of them from the time we get them if they're in a CMS payment option. And then last is physician network and ancillary scheduling. Many times you're going to go in and you're going to see that the physician in his office is calling to schedule. The ancillary departments, or if they're in the hospital, they're trying to schedule, so there's a disconnect. Okay. Milton, where are you pointing this to that it goes for you and doesn't for me? You know, I have this thing with electronic devices, I actually can make them stop.
I'll work for you.
You work for me, okay. So real quick, challenging, I just want to get to the case study and show you real dollars, because I know that's what you want. So we'll go to the next slide. What do these all have in common? So I'm not just talking about academic medical centers, multi-hospital networks, community hospitals, physician offices, retail, SNFs, home care. On the next slide, what you'll see is this is what they have in common. We're all driving volume. We want it to be easy, seamless, integrated, and coordinated. So that way we really know what's going on with our patients. Next slide. We need to have key performance indicators, and Roger, I guess, had talked about big data before and so forth. Absolutely, you need to have the data. We need to have the customer service perspective, an internal business model, and always innovation and learning, and get to the finances. So next slide. Here was the puzzle pieces I wanted to show you. You notice telehealth isn't on here. It's not on here because I don't want it on here. It's on here because these are the areas that are all scheduling. And if they're not talking to each other, then we have big, big dollar problems. How much? Let me share with you. We'll go to the next slide. The next slide. Here. These are centers that I've set up with my colleagues. And what we basically had to do is we put them in an actual call center, but we did it with real-time metrics. And so you see on the wall boards, and I'll show you closer what's on there, but it says the wall board displays. Everyone that's in this call center can see the wall board. They know how many calls are in the queue, what type of call. We know the disposition, if they're going to get a radiology appointment, if they're getting an orthopedic appointment. But if this isn't done, we've kind of already lost. The ship has sailed with the money. And so if your systems can fit into what we're trying to accomplish, I think it will make it a lot easier. Next slide. This is the national benchmark. You look at the very last column, it tells you. So we need to be able to have our patients, who wants to be on the phone or letting it ring for 3.5 minutes? Don't you want to hang up? Well, our patients were hanging up, or patients that I've worked with at other hospitals. We decided that we would do a study just on radiology. So I'm going to share that with you. So if you look at the benchmarks, the 4 categories are: how much does the person talk? Do they have enough knowledge to be able to schedule whatever the appointment is? So you have a knowledge base. Number 2, what's the abandonment rate? The national benchmark is 5%. If you're doing more than 5%, you're losing volume and you're losing your patient because the patient can go somewhere else, right? And then they don't go back to their physician if they go to another hospital. So these are all real problems that were happening. How do we fix it? Next slide. We put in a system, and so we can see, and my medical director who followed me around, basically he would just flip open his laptop or his iPad, and when people would complain, he could say, oh, no, I can see that we're down below 3%. We're answering within 31 seconds, 82% of the time. The disposition circle is what happened with that call. So now I'm seeing all these appointments in the blue. I'm setting up appointments. I'm getting them done. And I'm going through, did they need to reschedule? Did they need this? And every one of those little dots in the middle is a person. So every person that calls, we get their number and we have it. So then when marketing wants to go and send and do a campaign, we have the data for them. And then last but not least, we can tell if it's the blue hospital, the red hospital, we can tell where they're all coming from. And so at any point in time, if a doctor has a complaint, this is all fully recorded. It's measured. We have people listening for customer satisfaction, and we can get to it. Next slide. And we're pretty much done. How else could you help a hospital? Because if I can save money, then this is what I've done, then I convince my boss and the board, this is what we can do to even do better. So what you're looking at here is not only does it measure what's going on with the calls, you can see the staffing level. So we were able to take a group of people that were working, and we were able to give them, I don't want to say this, more work, but we were able to take them and then say, instead of just scheduling for certain diagnostic tests, now why don't we schedule for the physician test? So that was more of a clinically integrated system. We actually, in that large room, have a section for HR, so when the employees call and they want to know how much it costs for their procedure, because everyone wants to know what it's going to be out of pocket and so forth, we have staff there. We have another group that are nurses for transformation of care. They take care of the chronic, they take care of diabetes, they take care of other services that I know that you all would be rendering, so we need to have those connections. And then the last, if we could just go, Milton, to the next 2 or 3. Here's the real case study. This is what we did. It only took us 2 to 3 months to do this. We went through the whole system. We found out that what is the cost of doing nothing? I would also advise you to use that as a statement. If you don't do this, what is the cost? What will you lose? One of our call centers was losing $833,000 because they weren't answering the phone, and we tracked, and we tracked faxes and stuff. Another was losing 1.227 million. So $2.08 million lost, just lost, and that's radiology. I didn't even go through every other department. Next slide. So the bottom line here is there was an action plan. You do a gap analysis. You saw we were able to do that pretty quickly. We were able to work with IT, who became our best friend. Sometimes you need to be able to go and build a centralized station, but literally the systems that are out there, the staff could work at home. Stops call-outs. They could be, part of it, just like our psychiatry friends were saying. You can do the same thing with the staff. So we were able to show an ROI just for radiology of $1 million. That $1 million then was, let's do telehealth. So let's get that in there. We had telehealth, we had telepsych, we had neurostroke telehealth, but we really needed so much more for the patients. We needed it in our PACE program, we needed it in our home care, which we also found out that we were losing $1 million because patients getting discharged from the ED, if they don't have a PCP, they're just abandoned, they're out there. So we made sure that a nurse would always go check every patient, and we would make sure they get assigned a PCP. So I just wanted to give you a little bit of the gravity of the things that go on with hospitals and what we're looking at. And if you take 2 or 3 of these slides, I know you're so smart that you can come up with ways in which you could use one of those antidotes to come up with, here's a good plan for you that could save some money and that you could invest it in better care for the patients. So thank you all for what you're doing.
You were mentioning in one of your slides real-time scheduling. There are certain solutions out there where patients can schedule their own appointments from home. Have you used any of those solutions? And if you have you found any benefit in terms of revenue?
Yeah, yes. Actually, when there's a slide that I went through, and when it talked about the different puzzle pieces, that if they're not all working together, it's hard to bring in another service. But we were able to implement with the system we had. We can do Skype, we can do chat, we can do texting, and absolutely one of the other speakers said texting is really what people enjoy the most to do the scheduling. So that was helpful.
I think what I was trying to ask you was if a patient can make his or her own appointment from home on the laptop sitting in the middle of the night, and that appointment goes to your schedule automatically. Have you used any such service? Right.
We weren't at that point yet, but what you, I think, are talking about is more like the Healthcare Advisory Board and what Memorial Hermann did. They have exactly what you're saying, so if you wanted to check out, you could see that.
Over there.
This may turn into several questions, but you had talked about telehealth in the hospital. On the backside, you've got readmission penalties for Medicare. Have you had any success with any programs where you look at the patients that are being discharged for the 5 types of readmission penalties to look for a solution to decrease those readmissions using telehealth?
Well, my favorite saying is, and I know it shouldn't be never discharge the patient, but it's never lose your patient. And so we have a group of transformation of care nurses that work with the chief medical officer, and that's their job. I mean, it's amazing what the government is also giving us with the data. So if Mrs. Smith even lives here and goes to Florida for the winter, well, I don't know why she would go to Florida if she lived here, but anyway, she goes to a different state, we can actually get that data and we can track that patient. So there's a lot more information out there than we've ever had. Does that answer your question?
Well, there's a lot of talk about community paramedicine, but then when you look at the different ways that they're implementing it, it doesn't really take care of the readmissions and actually take care of that patient. So I was curious to see if you had any program or any success with decreasing hospital readmissions using
Yeah.
telehealth.
Yes, we do. We do. We've had to go through the bundled payment process. We also have to monitor. So we have high-risk case managers that monitor the patients that are more likely. There's analytics that's out there. I can get the name of the company to Milton that can be used. Trinity Health has its own system that they were using, and that basically kind of flags the patients so that way we're double checking on them.
Payment models for community paramedicine or someone home health going in and doing those follow-up visits to reduce the readmission penalties. Have you guys have a preference whether it's a per event or per patient, $1,000 over 3 months you follow, and they give you back metrics to show that they have helped you reduce the number of readmissions?
Yes, we do measure that, and actually Mercy Health System, the Trinity branch in that area, has one of the largest home health, and even the other hospitals utilize ours because they've had a long history of doing quality work and what you're saying.
Any other questions?
Thanks. Great talk, by the way. It was very good. In a hospital administrator's mind, when they're looking at establishing or building a telehealth program, what kind of return on investment timeline are they looking at where it's something that would really get their attention? Is this a short-term project for them or long-term? If you could help us with that.
In my experience, we usually go 3 years. We'll have a 3 to 5 year plan. I was only given a year. I was fortunate enough that we had a master contract. That's another thing you might want to look at in systems. If they have a master contract with someone and you can be, as your company, have an association, you get quicker to the top. So ours was really the pilot for all of Trinity, and you saw the return on investment. I mean, within 2 weeks, we were down to 3%. Abandoned calls versus 29, and the doctors were so much happier. So now everybody wanted us to schedule for their other departments. So, yeah.
Okay, thanks.
Okay. Any other questions? Okay. Thank you so much for that. Okay.